Okay, so you're probably wondering why I'm here talking. We have all these physicians. I'm the only non-physician talking. And I probably need to have my head examined because I actually volunteered to do this. So we have a lot of great clinical information that we've been given. I have learned a couple of tips. One is that we are allowed to have a Star Trek slide, so that will be coming up. We can invite our spouses. That didn't work for me. So we'll just go ahead and get started. I have nothing to disclose, and I am not part of Dr. Concha's Colombian cartel. The Cuban cartel, maybe not the Colombian one. Really the objective here of my presentation is going to be to review the clinical considerations of the new oral anticoagulants, if you were wondering what that abbreviation NOAC stood for. And basically I'll be reviewing their mechanism of action, some differences as far as pharmacokinetics, indications and dosing, lab monitoring, and reversal strategies. So it's a lot to cover. Anticoagulation prior to the 21st century, really all we've had is warfarin since the 1950s. One oral anticoagulant, and after 70 years, I wouldn't say we're that great at it still. But we have a lot of data, certainly. Some of the strengths and limitations you'll see are the same. Frequent monitoring is most typically seen as a limitation of the drug. On the other hand, it is a way to have a lot of contact with a healthcare professional and know where that patient is, to what degree of anticoagulated they are. Prescriber familiarity, because it has been around so long, lots of indications, relatively low cost to the patient for the drug itself, and it's reversible. On the other side, you'll see some of the limitations there. Of course, there's lots of interactions that we're all aware of. It does have that slow onset, which then means it requires bridge therapy. So that brings us to today. The new oral anticoagulants, in contrast to warfarin, have a short half-life. Again, I see that as a pro and con. You can start it, it starts to have an effect right away, which is great. You can stop it and the effects are reversed relatively quickly, but that does play a factor with, I think, patient compliance if they're not taking their doses, because the anticoagulant effects are quickly reversed. There is no monitoring. Could be a pro and con again. We don't have any way to monitor these. Very predictable dose response, which allows for fixed dosing. Minimal drug interactions, and of course the data has shown that they are at least as good as warfarin, if not better, and lower risk of intracranial hemorrhage. Possibly higher risk of GI bleeding, but everyone says they'll take a GI bleed over a head bleed. Limitations, again, just the lack of familiarity. The no reversal agent is a big issue that we're currently dealing with. And of the limited data and studies that are out there, there are none that are in patients that are actually hemorrhaging and bleeding. One thing I do want to point out with these, and I just copied one of the package inserts, is the fact that premature discontinuation of these agents leads to an increased risk of thrombotic event. Again, that ties to the fact that they have such a short half-life. So you'll see this with Eliquis, as you will Xarelto, Savaysa, Pradaxa, all of them have this same warning. So the coagulation cascade, it's hard to have this talk without including this, so this is my Star Trek slide. And it is important to just kind of look at it so that as we're talking about these agents, we can better understand how they work and how reversals might work. If you look at the green circles, this is the coagulation cascade with all the coagulation factors that ultimately lead to the formation of thrombin and then your fibrin clot. The green circles is basically where warfarin works. Those are the coagulation factors that warfarin inhibits. It's also the factors that we replace when we're using a prothrombin concentrate complex that I'm going to talk about later. Direct thrombin inhibitors, which is dabigatran, will directly work on thrombin and inhibit thrombin, whereas our anti-10A inhibitors, which are listed here, is going to work right on 10A. So what are our agents? So I said since 1950s, all we had is warfarin. Well, since 2010, these agents have all been approved. So we have the first, which was dabigatran, and on here again we see where they work on the coagulation cascade, followed by rivaroxaban, apixaban, and just this year, edoxaban. They all have a relatively short half-life compared to the 40 hours or longer with warfarin, with the longest half-life being dabigatran and the shortest rivaroxaban. Also, dabigatran does not have very much protein binding, significant amount of renal clearance, and those properties are what contributes to the fact that it is dialyzable, and that'll play a factor later when we talk about reversal. This is some of the stuff that I think is so important because now there's so many new agents and they're all dosed and have their own little nuances, is kind of keeping this straight, quite honestly. So you can see when you look here, they have different types of indications. They're not all approved for the same things. Their dosing is obviously all different. Some of them you need to take with food, specifically the rivaroxaban with the 2 higher doses. You know, this for the VTE treatment, you continue at the 15 BID for 21 days. If it's apixaban, it's 10 BID for 7 days. So the point just being, it is important to know their differences. Secondly, is if they have renal or hepatic impairment. So I just showed you the slide of what you do if they're normal. Well, here is their differences, again, if there's some degree of renal impairment. It's always interesting, too, to see the newest agent, edoxaban, is also contraindicated in patients with very good renal function. That is the first drug that actually has 2 limits: poor renal function or too good renal function. It should not be used. Other interesting thing is, although there may be recommendations for clearances in the 15 to 30 range on some of these drugs, if you're using it for one of the other indications, it's to be avoided once the clearance is less than 30. So even dosing differs significantly when you can and shouldn't use it. Apixaban requires adjustment of the dose if 2 of the 3 criteria are met. It's not based on renal function alone. So if you have a patient with severe renal impairment and that is their only problem, basically, they do not require a dose adjustment. And lastly, I'll just mention drug interactions certainly differ. They are all affected by P-glycoprotein, and only dabigatran does not have cytochrome 3,450 interactions. And also, especially in the hospital setting, we need to know, well, which ones can we crush, because oftentimes we may have a patient with an NG tube. So dabigatran is pH dependent, and you'll have significant absorption if it's crushed, and therefore increased toxicity. So we thought we had all these agents, but guess what? There's another one in the pipeline, and that is betrixaban. So looking at betrixaban, which is currently undergoing phase 3 clinical trials, you can see that this one has a longer half-life. It also does not have any renal clearance, so that may be an interesting option for patients as well who are severely renally impaired, and no significant THRIP and CYP interactions, which are all good things. This trial here is actually one that we are participating on, and Dr. Contra, if you have questions, I'm sure he'd be happy to talk to you about it. But it is an efficacy and safety study comparing extended duration betrixaban with the standard of care enoxaparin. So this will be patients who are going to be randomized to either betrixaban orally for up to 35 days versus enoxaparin for DVT prevention. So how about laboratory monitoring? Well, this table was probably one of the ones I found that I thought was kind of simplest to keep straight. We have the direct thrombin inhibitors, and the most sensitive is going to be this TT or thrombin time. But it is so sensitive that even small amounts of drug are going to make this number go way off the chart, so it's not even really usable. So if you think about it from a practical standpoint, probably with direct thrombin inhibitors, you're looking at an APTT. It's qualitative only. So what do I mean by that? If it's elevated, you can say yes, the drug's on board, or no, it's not. It doesn't tell you what degree of anticoagulation your patient has. The way I remember this is because we have a lot of parenteral direct thrombin inhibitors. So for those of you that have used or are familiar with bivalirudin, which is Angiomax, Reflutin, Lopiridan, which is now off the market, or Argatroban, those are the drugs in the same class, and we monitor those using APTT or even ACTs in the cath lab. So that's how I kind of keep which one is APTT versus my 10A inhibitors, which primarily impacts the pro time /INR. These labs down here will all be interesting one day maybe, but at this point it's not prime time. They're either not available, we don't have the appropriate calibrators for them, we don't know the thromboplastin and reagents that are used, so we don't have established therapeutic ranges. So it's something that someday we may be able to use, but not right now. So patient case. We have a patient that comes in, has a history of AFib, is admitted for cardiac ablation. And on the day of his procedure, he was on warfarin prior to presenting. He has a pro time 20.5, an INR of 1.76. Warfarin gets ordered post-procedure, 5 milligrams is given that evening. And then later that night, we get an order for rivaroxaban. You call the physician and their thought being, well, I need to bridge, right? I want to bridge because my INR is not therapeutic yet. I don't want to have to start an IV infusion of heparin. I don't want to give this patient a sub-Q injection of a low molecular weight, and insists on bridging in this manner. Well, the next morning, the INR is 7. That should not come as a surprise. We just talked in the slide before that these agents are going to increase your pro time and INR. It doesn't mean that tells you that that patient is super anticoagulated and is about to bleed, although that's my fear, that someone will come behind here and now order vitamin K. So that's not the case. It's an elevation from these labs. But of course, now everybody's freaking out, quite honestly. They repeat this in 4 hours. We're still elevated, but over time, and if we got to the trough like 24 hours out from that rivaroxaban dose, you'd see that effect minimized. So while the night before we could not talk the physician out of this, the next morning everybody was freaking out, including the patient who was on warfarin, knew what the goal INR is, and now is concerned that their INR is 7. So ultimately the warfarin was discharged and the patient went home on rivaroxaban instead. Okay, reversal strategies. Well, there's basic reversal strategies. Number one is going to be stop the anticoagulant. Although if you look at the package inserts for any of these drugs, it will actually tell you to try not to stop the anticoagulant if you can avoid doing so, even if your patient is bleeding. Again, going back to the fact that they're going to be at higher risk for clotting when we interrupt these therapy. In reality, your patient's bleeding, especially any kind of severe major bleed, the agents are stopped. I kind of put check antiplatelets because sometimes I feel like these patients present, everybody's focused on their anticoagulant and possibly overlooking the fact there may still be on an antiplatelet or aspirin that also needs to be addressed. As I mentioned earlier, dabigatran is dialyzable, so in some patients that may be an option. It's obviously not practical and it's not going to be an option for everyone, but we actually have done dialysis on some patients. Activated charcoal, especially if they've just taken a dose and present within about 2 hours, but some of the literature suggests possibly even as long as 6 hours, but certainly within that 2-hour period. You know, beyond that, of course, there's always decreased benefit really and some increased risk of aspiration and all the other things with the activated charcoal. Again, there is no specific reversal agent that's approved, so it's going to be supportive measures, and this is where I'm going to talk about the PCCs and what that is. So currently FFP, the fresh frozen plasma, which kind of more of a support of replacing all the coagulation factors in protein. There's recombinant factor 7, which is Novo-7. And then if you've heard the terms, there's discussions of 3 factors PCC, 4 factor PCCs, and the activated. So activated is also 4 factor. So why are these 3 factors? Because they only contain 2, 9, and 10. And these are the only ones approved in the US, by the way. There are many, many more approved throughout the world. So we actually have just very few of them. 4 factor, how do they differ? Well, these have factor 7. That is the addition. And in this case, in the FEBA case, it's activated factor 7. A couple of other things just to point out. Some of them may have some of the protein CNS, but also some have a little bit of heparin in them. And so just keeping that in mind, the package inserts will also say if your patient has active HIT, that it's contraindicated because of the heparin component. That's where that plays a role. So FFP, we kind of all know some of the limitations that have already even been mentioned, the large volume, the thawing takes a while, et cetera. But this is certainly still going to be an option, you know, in many cases. Recombinant factor 7 was alluded to earlier as well. That's a product that really is approved for the management of patients with factor 7 deficiency or hemophiliacs with inhibitors. However, when this product first came out, and it really started to be seen as kind of the magic drug to give a patient who's bleeding, and it started to be used quite a bit off-label. And over the years, we've seen more data kind of come out now saying that, you know, their risks of thrombosis may outweigh any benefit, and it's actually we're stepping away from this use of this agent as much. Short half-life, you know, about a 2-hour half-life, so it may need frequent administration. And cost, these doses, it has a huge range of dose, you know, 90 to 120, but can cost $5,000, $10,000 for 1 dose. So the 4-factor PCC, this is the first one approved in the US, the first 4-factor period, and the first PCC for an actual reversal. So this is approved for reversal of the vitamin K antagonist, which is warfarin, in adult patients with acute major bleeding or who need an emergent reversal. So again, I want to stress, it doesn't mean every single patient needs to get Kcentra, but in certain patients in which it is a life-threatening bleed, or it may be an intracranial hemorrhage, we now have Kcentra available. You'll notice that it is dosed based both on INR and weight, up to 100 kilo max. And as I mentioned, the contraindication because of the heparin component. And the latest CHEST guidelines, and there are many different guidelines out there, actually now do recommend for vitamin K antagonists, major bleeding, PCCs over FFP, which forever we have always heard just use the FFP. So if it's good for warfarin, then is it good for the new oral anticoags? Here is a small, healthy subject randomized crossover type study. So what that means is our 12 patients got 1 drug, then they received the reversal, you know, the PCC, then there was a washout period, then they received the other drug. So the 2 drugs that they were given is dabigatran and rivaroxaban. And what we found is that if you gave rivaroxaban, your baseline was it increased your pro time. Okay, we've already established it's going to do that. And it decreased your endogenous thrombin potential times, whatever. But your Cofact, which is another PCC not available here in the US, reversed it. You can see because the arrows are in the opposite direction, so it did work, it reversed it. On the other hand, with dabigatran, which I told you is extremely sensitive to TT, that's why it's very elevated, but will elevate all of these coagulation labs, the PCC actually didn't have much of an effect. So from this some institutions have actually decided, you know what, we're not going to recommend or use PCCs for dabigatran reversal. However, the jury is still out. You have to remember there's a lot of limitations here. This is just healthy subjects. This is just looking at coag labs. We don't know how this is going to translate into actual clinical outcomes. So way too premature. But that's part of the problem here, is that we really don't have data. The activated 4-factor PCC on the table, which is FEBA, got its name exactly because of what it is. It's a factor VIII inhibitor bypassing activity. This one too is approved just for hemophiliac patients with inhibitors. But for off-label use, it's now been tried a little bit in some of these reversals of the new oral anticoagulants, as well as warfarin. There's actually a little bit more data and studies for warfarin. But if you think about it, using PCCs for warfarin makes sense, and it is a reversal, right? You've got warfarin that's going to inhibit your body from being able to make factors. It inhibits your body from making factors 2, 7, 9, and 10. So how do you reverse that? You give factors 2, 7, 9, and 10, right? There you go. You've accomplished it. These new oral drugs don't inhibit the formation of these factors. They actually work to block the factors once they're there. So you can kind of see why it's probably not going to work quite the same. But so the risk and the concern, maybe some theoretical, some real, it's still a little early maybe to tell, is certainly thrombosis, because it does have factor 7 in it. I'm sorry about it's not that clear, but the point that I wanted to make, and I thought this Dr. Siegel here had the best table that just summarized the data on the PCCs. This was with dabigatran specifically, and this says animal studies here. So animal studies for PCCs, what have they found? Activated PCC or factor 7. And some of it is a little bit conflicting. No reduction in blood loss, and these are animal studies. Reduced intracranial hematoma, reduced blood loss, reduced bleeding time, but no effect on the coagulation test. APCC, no reduction, you know, not all that great, really. This corrected some tests, no correction in other tests, corrected some things, no correction, and this is in vitro now. That means they took blood out of the patient and just did laboratory testing and looking at coagulation tests. What do we have for other studies? The human healthy subjects that I just reviewed with you. So again, not a lot of data and still some conflicting information. That's similarly what we see with the 10As. Here's our animal studies, our ex vivo type of studies, and then another similar type of study in healthy subjects where they looked at different concentrations, different reagents, and kind of, I think the jury is kind of still out. So that brings us to some exciting times here, which is new agents in the pipeline. Idarucizumab, andexanet, and aripiprazine. I think that's how there's. Okay, the first one, which is referred to as a DabiFab. It is a monoclonal antibody. So many drugs these days are monoclonal antibodies. And it has much, much greater affinity for the dabigatran than the dabigatran will with the thrombin. And so therefore, it can cause immediate blocking of the effect and therefore reversing it. In early animal studies so far, it has not shown to have procoagulant type properties, which would be amazing, like actually like too good to be true. Because of course that's always a concern. You have a patient on an anticoagulant for a reason. So now not only have you stopped that anticoagulant, but you've potentially overcompensated. So that risk of thrombosis, you know, is real. This is Japanese, but that's because all of these studies are mostly done in Japan. The phase 3 trial that is currently ongoing is the reverse AD trial in patients who have bleeding on dabigatran. So that is currently enrolling. The next agent in the pipeline is andexanet, which is a recombinant factor 10A molecule that has been enzymatically modified so that it is inactive, and it directly binds and reverses the 10A inhibitors. Again, this agent is in phase 3 clinical trials, and we are also involved in these trials. The trial that we're currently doing is an open label prospective study for patients on 10A inhibitors who have acute major bleeding. So all patients enrolled in here will receive the drug. It's not like a 2-arm versus placebo. Currently, it's looking at a apixaban, rivaroxaban, or enoxaparin. Edoxaban may be added down the line. It is an infusion, a bolus followed by a 2-hour infusion depending on which agent and the timing and things. So again, really exciting and another study that we're involved in. And the last agent that I will mention is this iresine, which is a small molecule that can bind to many of the different anticoagulants, including heparin, the low molecular weight agents, direct thrombin inhibitors, and it is given as an IV infusion. And so far it looks promising as well with immediate reversal of clotting times when it has been administered. So that's ongoing as well. So once these agents become available, certainly then we will have a specific antidote basically for patients having bleeding or needing emergent reversal. What'll be interesting, what's always interesting is to see what the price is, but I have to look at that end. So in summary, I think with these new oral anticoags, really as with any medication, but certainly medications that have such a potential risk of hemorrhaging and complications, appropriate patient selection is so key. Really knowing and understanding the differences of these agents, it gets a little tricky and harder to stop keeping them straight because we have so many and more coming. I think it's important to know what their FDA-approved doses are because I have seen variations from that, and that is problematic. If it's a twice-a-day drug, it needs to be given twice a day, again, because of that very short half-life. Reversal, there are no reversals specifically yet, several in the pipeline. PCCs, however, may be considered. If it's the dabigatran, you've got dialysis. Look at your antiplatelets if they're on that as well. And it's always a risk-benefit assessment, obviously. I'll just mention for intracranial hemorrhages, we're very proactive in treating them just like an ischemic stroke. You can't take a let's wait and see approach. We're now actually using the same types of get with the guideline times that we do with ischemic strokes. For example, of door to needle of 60 minutes. With alteplase, we're applying that to the treatment of these patients with reversal as well. And again, target-specific reversal agents are in the horizon. So one last case here. Patient is admitted with right-sided weakness, has a history of hypertension, coronary artery disease, had a TIA a couple of weeks ago prior to admission, has HIT. He's a status post-TIA, and at that point, 3 weeks ago, he'd been converted from rivaroxaban to dabigatran, and his last dose was 14 hours prior to arrival. So his allergies are listed, and what are some possible treatment options for this patient? So first, is activated charcoal an option? No, probably not. We're 14 hours out, so not an option. Hemodialysis, that's an option. We are out quite a bit, but you'll still get some removal. FIBA, one of the PCCs, that's our activated PCC. Yes, how about Kcentra? No. Okay, not Kcentra in this case only because of the heparin and HIT. Okay, I'd like to acknowledge some folks that helped me out here. Any questions?